I think it is better I should call all three panelists, Dr. Robert Black, Dr. Tessa Wardlaw, and Dr. James. Nice to meet you. Thank you very much. Good morning, ladies and gentlemen. I'm happy to chair this important session of the second day on the subject, reducing child mortality. What have we achieved? Through this session, we hope to have an analysis of the current status of child mortality, what has been accomplished in the past, and the various interventions that have led us where we are today. The two subtopics we would be looking at relate to global under 5 mortality, where do we stand today, and the countdown report data, methods, and country profile. We have a very distinguished panel whom I briefly introduce. First, Dr. Robert Black is the chairman, Ajgar Burman, professor in international health. Dr. Black is MD, MPH, and he has focused in research and professional activities on reducing child death. And everybody knows about him, much, I think, much better than me. Second, Dr. Tessa Wardlaw, who is the Chief Statistics and Monitoring of Associate Director of the Division of Policy and Strategy from UNICEF. And third panelist, because time is very short, so I'm not going in detail. Third panelist is Dr. James from Uganda. He is a medical doctor, trained as an epidemiologist at the London School of Hygiene and Tropical Medicine. Currently, he is working for Malaria Consortium in Uganda. Before I ask the panelists to speak and share their knowledge on the subject, I would request them to throw special focus on some of the key issues like what has been successful, what has worked, what are the barriers or challenges we have encountered, how does the current status different from country to country, what have we learned from our successes and mistakes, and how is the knowledge translated into both policy and practice. With these opening remarks, now I request the first speaker, Dr. Black, for the presentation for 10 minutes.
Thank you, Minister Tirath. Well, I will talk today about where we are and how far we have come, particularly in the time period since 1990, and how this might give us some signals for how we might proceed in the future with even more accelerated reductions in child mortality. I'd first like to recognize my colleagues, Li Lu, with whom I've just published a paper on the causes of child death, and Danson Yu and Tessa Wardlaw from UNICEF for their work with the interagency group on child mortality estimation. The references for, let's see if this will work. The references for this presentation really are primarily these two. The levels and trends in child mortality comes from the UN Interagency Group on Child Mortality Estimation, and this is their most recent report in 2011. And the causes of child death and the trends in cause-specific mortality comes from our collaboration with WHO and UNICEF in the Child Health Epidemiology Reference Group. And this publication just came out in Lancet this week, although it was online for a couple weeks prior to this. The information in more detail is available on the churg.org website, which has all of the information for, in fact, all of the countries of the world for causes of death, the number of deaths, and the cause-specific mortality rates for all countries, as I say, from the year 2000 to 2010. The trends in under 5 mortality are shown in this figure. And as you see, there's been a somewhat sharp decline, but in fact, even at this point in 2010, much more decline in mortality would be needed to reach the MDG target of 29. The other thing that's obvious in this figure is the red line below is the neonatal mortality rate. And that has been declining at a slower pace than the under 5 mortality as a whole. And this is a point of considerable importance, because if we're going to achieve greater reductions in mortality, we're going to have to increase the slope of decline in the neonatal mortality. And looking back then from 1990 to 2010, I'd like to show you the under 5 mortality rate. And this is by the Millennium Development Goal regions of the world. And as you see, although the regions are starting from a different point of under 5 mortality rates, the decline in under 5 mortality is apparent in all of the regions of the world. In fact, the under 5 mortality declined in all regions, and, sorry, I'll go 2 at a time. The decline in mortality rate by these regions has been quite dramatic in many of them. In fact, as you see here, the regions that have reduced mortality, in fact, many of them by at least 50% during this 20-year time period. However, the mortality rate in the countries of the world still differs very much. And in this map of the world, we can see the highest mortality rates shown by the orange and red colors are primarily in sub-Saharan Africa. The areas in green also still have a substantial mortality, so that includes South Asia as well as some countries in sub-Saharan Africa. So this is where the challenge is, in fact, for further reductions in the child mortality. In terms of the number of deaths by MDG region, as you see, really half of the deaths are in sub-Saharan Africa and another large proportion in southern Asia. So again, a focus for attention in the future. And if you look at it by country, there are 6 countries that explain more than half of the under 5 deaths: India, Nigeria, Democratic Republic of the Congo, Pakistan, China, and Ethiopia. So these are, again, countries that must do much more if their own mortality rates are to be reduced and if the global mortality is to be reduced as well. So this is overall under 5 mortality, but we need to look at the causes of death, because our interventions, as you know, are targeted to specific causes, and we have to see how these causes have been reduced in the last decade in particular, and where are we now. So this is the current distribution of the global causes of child death. The number 1 cause of death remains pneumonia. On a global basis, complications of preterm birth is now number 2 as a cause of death, and diarrheal disease is number 3. So there are a number of other causes, as you can see, and I won't go through it just for the sake of time. Another important thing to note, though, is that through synergy with infectious diseases, undernutrition could also be considered to cause or be a major determinant of about 35% of child deaths. I don't have time to go through the causes by country, but this is available in that countdown report. The information that I'm describing was used for the countdown report by countries, and you'll see these pies there for each country. But I did want to show one contrast, which is the contrast between the MDG region of Southern Asia and Sub-Saharan Africa. In the pie on the right, you can see in Southern Asia, actually the neonatal deaths represent 50% of all the deaths. And you can see again that pneumonia, diarrhea, and some of the other infectious causes continue to be important. Sub-Saharan Africa is different as a picture. Virtually all of the other regions of the world look mostly like the Southern Asia picture, but Sub-Saharan Africa is different. Neonatal deaths are 30% in this region. However, the actual rates of neonatal mortality are highest in this region. And the reason for the proportional difference is that the total mortality is much higher, and the number of deaths and the rates of death in the 1 to 59-month age group is much higher in Sub-Saharan Africa. So this has not declined so much. And then we can look at what are the causes in that age group. Certainly, malaria is a notable difference in this region versus the rest of the world. And I think we can further say, now, looking at these causes in 2010, how far have we come in the last decade? And so if we look at this chart that shows the reduction in under 5 mortality rate, the bar on the left of 73 per 1,000 live births is the 2000 figure. And the bar on the right, the truncated bar, 57 per 1,000 live births, is the 2010 figure. And what is shown in this, as they call it, waterfall figure, is that 50% of the reduction in the deaths during this last decade has been reduction in the deaths from diarrhea, pneumonia, and measles. And of course, diarrhea and pneumonia continue to be major causes of death. Measles has been reduced very substantially, and we need to continue the immunization program so that measles will not come back. But at this point, measles is a much smaller proportion of death than even a decade ago. I'm going to show some further figures, and I'm not sure how well they will be able to be seen back there, but I only make some very general points about them. You heard yesterday from Hans Rosling about the annual rates of change, and this is what I'm showing here. So on the vertical axis is the annual rate of change in mortality, and this is a percent. And the horizontal axis is the under 5 mortality rate in the year 2000 per 1,000 live births. The colors represent the different regions. I've only excluded the high income, low mortality countries just so that you could see a little more on the figures. So this is all of the other MDG regions. And I think what you can see in this figure is that first, the 0 would be no change, of course. The red line, the horizontal line, is the 4.4% rate of annual decline in mortality that would be necessary to reach the MDGs during the 1990 to 2015 period. So just as a reference, that 4.4 figure, 4.4 line is on the figure. And what you can see is that in fact, and this is for pneumonia, there are many countries in the world that have reached or even exceeded that 4.4%. And when we're talking about achieving the more ambitious goal of under 5 mortality reduction that we have been discussing in this meeting, we are certainly talking about annual rates of change that are 5% or up, even in some countries up to 10%. So you should look at the dots that are on the far left and below the red line and see that there in fact have been many countries that have had the annual rates of decline in pneumonia mortality that have been 5 or even 10% or more. And that unfortunately for the global picture, many of these countries are in the lower mortality countries that already started in year 2000 with lower mortality rates. And the countries that are off to the right part of this figure that start with very high mortality rates, not so many of them have annual rates of decline that are below the red line. Some of them do, though, and some of them have quite large reductions, even up to 10% in the rates of pneumonia. So I'll show quickly some similar figures now that I've explained what the figure is telling us. And the next one is for diarrhea. And again, as you see, there are many countries in virtually all of the regions of the world that have achieved mortality declines here, and I'm changing the scale on this because of some very large declines that show up here. But you can see here that annual rates of decline, even of 5 to 20%, have been achieved in the last decade. And finally, malaria. So this is only shown for sub-Saharan Africa, and here the results have been much more variable. We would like to see all of the countries, now that we have very powerful interventions to prevent and treat malaria, we'd like to see more of the countries achieving these very large reductions that have been achieved in some countries, even 10 or 20% annual rates of decline in the last decade. And I think this tells us that we have a challenge and a long way to go, but we also have an incredible opportunity with the tools we have now to achieve very large reductions in malaria with very concerted effort in these countries in Africa. And as I said, we know we have to work more on the major causes of death in the neonatal period. And so I'll show then, this is intrapartum-related complications, so complications of delivery. In previous publications, this may have been called birth asphyxia, so the particular complications at the immediate time of delivery. And as you see here, the countries of the world are not doing nearly as well with this. Most of the countries, in fact, are above the red line of 4.4% annual rate of decline. And I think, though, if we look at the countries over toward the left part, I think we also see that there are many countries that have had much larger rates of decline, even 5 or 10%. And then I would just go to the final one of these figures on preterm birth complications. And this is another huge challenge because most of the countries of the world have not had large rates of decline in mortality related to preterm birth complications. But we know that some have, and that there are more things that could be done. So I'll quickly end with a few conclusions. That is that child mortality has declined by 35% globally from 1990 to 2010, and by more than 50% in many world regions. The high rates of child mortality persist, of course, and unfortunately, especially in Southern Asia and Sub-Saharan Africa. And these regions now have 82% of the deaths of all children in the world. We know that 2/3 of the child deaths are preventable or treatable infectious diseases, especially pneumonia, diarrhea, sepsis, and meningitis, particularly in the neonatal period, and malaria. Deaths in the first months of life now constitute 40% of all child deaths globally, and the complications of preterm births and intrapartum-related events are the major causes. And as I said, outside of Sub-Saharan Africa, this is even 50%, so a clear area that needs greater attention. So if we compare the figures of mortality in the year 2000 with 2010, the number of child deaths has decreased by 2 million per year, from 9.6 to 7.6 million, and 50% of that decline is due to reductions in measles, diarrhea, and pneumonia. So the annual rate of change in child deaths has not been sufficient to achieve the MDGs, but the rate of change for all of the major causes of death in some countries, and in fact in some instances for certain diseases in many countries, have exceeded this 4.4 rate and have achieved rates of 5 to 10% or more. So it gives us some hope that other countries could emulate this success, and that these kinds of rates are feasible, especially with the technologies that we have, or that in fact we may have by the year 2035. Thank you very much.
Thanks, Dr. Robert Black. Wait. Thanks, Dr. Robert Black, who has given nice and broad presentation on global under 5 mortality. Now I request Dr. Tessa to deliver the presentation on global, the countdown report data, method, and country profiles. Thank you.
Thank you very much, Minister Tirath, and good morning, everyone. As Professor Bhutta already said yesterday, the countdown to 2015 is truly an extraordinary partnership. It involves many, many important partners. Since 2005, the countdown has been tracking progress on those interventions which we know can reduce both child and maternal deaths. So in this presentation, which I hope will come up soon, we would like to share with you the main findings of the 2012 Countdown Report. And we will do this in 2 parts. I will begin by providing some background on the data and the methods of the report, particularly focusing on the country profiles. And then my colleague, Dr. James Tibenderana, will summarize some of the key findings of the report. Oh. Okay, let me maybe begin by just saying, what does the countdown monitor? The countdown focuses on tracking progress in the coverage of critical interventions along the maternal, newborn, and child health continuum of care. It also tracks health systems and policies, and that provides important information, contextual information for interpreting the coverage gains. The countdown also tracks progress in financial flows to maternal, newborn, and child health, as well as monitoring equity in intervention coverage. I really need these slides to, to make sense here. But maybe what I can do in the interim is just highlight what the important sources of data are. Any global monitoring effort begins with collecting high-quality data at country level. And those data need to be collected in a standardized fashion that will allow for comparisons between countries and over time. And for the foreseeable future, the main source of that type of information are population-based household surveys. There are 2 main sources of household surveys that I would like to highlight, and those include the UNICEF-supported multiple indicator cluster surveys and the USAID-supported demographic and health surveys. And I will show you the map here that highlights the 75 priority countdown countries, which make up more than 95 of all child and maternal deaths. The countries shaded in red are those that have conducted mixed or multiple indicator cluster surveys for the purpose of this report, and the blue countries are those that conducted DHS surveys. I would just like to mention one other important aspect of household surveys, and that is that they allow us to disaggregate the information. They allow us to look at different subgroups in the population by wealth quintiles, by ethnicity, by religion, by age, by maternal education. And this really enables us to examine in more detail the inequities that occur in the population and to assess trends over time. Now let me move on to the country profiles, and I'm very glad the slides are back up. So the country profiles indeed are really at the very heart of this monitoring effort. They bring together the latest coverage data and other key information and into one easily readable reference document. They present both the current situation as well as trends over time, and they highlight the gaps and areas that need further attention. This is a snapshot of one of the country profiles. For illustrative purposes, we're using the country profile for Malawi, but I should say that similar profiles have been prepared for all of the 75 countdown countries, and those are available at the back of the countdown report. I'm just going to walk you quickly through a profile. This is the first page. It includes information on demographics, including, of course, the trends in child and maternal mortality. It includes the intervention coverage indicators for maternal and newborn health, including the continuum of care. It also provides the information on the left there in that blue chart on equity, as well as child health and nutrition. Now I'm just going to focus in on a few of the key graphs just to illustrate what we can learn from these profiles. These are the trends in Malawi on under 5 mortality and maternal mortality. And as we can see, good progress is being made in reducing both under 5 and maternal mortality, but overall the rates are still too high. This slide highlights the continuum of care, and in the case of Malawi, we do see variable coverage along the continuum of care. And the first page of the profiles also include important nutrition-related indicators. On the left, we see a steady reduction in both underweight and stunting levels, and also some very exciting improvements in exclusive breastfeeding rates. This graph shows the socioeconomic inequities in coverage. And in the case of Malawi, as you can see, the bars are quite narrow, which indicate equitable coverage in many of the coverage indicators. However, I do want to highlight the fact that for many of the countries that we're tracking, we see much wider bars for this particular graphic. And that, of course, indicates important inequities between the rich and the poor that really need urgent attention. So the second page of the profiles includes continuing information on demographics, including the distribution by cause of both child and maternal deaths, as well as maternal and newborn health, child health, and water and sanitation indicators, and also information on policy systems and financing. For Malawi, as is the case for many of the other indicators, as Bob also mentioned, close to 1/3 of all under 5 deaths occur in the neonatal period. Other important causes in this case include malaria, HIV and AIDS, pneumonia, and diarrhea. I did not want to forget to mention that undernutrition is a major underlying cause of child deaths. So we saw then that Malawi has malaria as a major cause of death. So how are we doing in terms of prevention? We see encouraging improvements in the use of insecticide-treated nets, although the overall levels for children sleeping under ITNs is still low. This chart shows the trends in the use of improved sanitation facilities, an important indicator to track, particularly with respect to diarrheal diseases as well as others. And here we see on the left important improvements in the use of improved sanitation facilities. However, as you can see on the right, still 10% of the population practices open defecation in rural areas. So finally, the country profiles include important information on critical determinants of coverage across the continuum of care, such as development of national policies and systems, as well as external resource flows. So just to summarize then, the countdown data are critically important as an instrument for highlighting successes and identifying areas that need more attention. And the countdown provides a fundamentally important foundation for translating data into action. So thank you, and let me now hand the mic over to Dr. James Tibenderana.
Thank you very much, Tessa. Honorable Minister, good morning, everybody. In the time I have allocated, it will be difficult for me to summarize all the information that's in this report. And so I encourage you to each pick a copy and look through the 75 country profiles and the synthesis that's contained. What we can see from the information is out of the 75 countries, some countries are making progress towards achieving MDG 4 and 5. However, the majority of countries are still lagging behind. What we can see from this chart is that along the continuum of care, coverage is variable. What we find is that for some indicators, like antenatal visits, coverage is about 88%, above 70. Immunization, above 70. But what you find is that for some of the proven interventions, like access to IPTP, access to L-Alliance, treatment for malaria, are still far below expectation. And what we've noticed is that around the period of birth and in childhood, there's significant gaps in coverage. And this seems to be related to the health systems that have to be responsive and available to make sure that women and children have access to treatment and preventive interventions. 23 of the countdown countries have achieved the MDG for drinking water. But we still find that 780 million people still lack access to improved water sources. What this chart shows you is that a large proportion of countries are making gains over multiple interventions. And what it shows you is the number of countries, and the upper bars are those that are making gains. What you'll find is that some countries are not making any progress, and importantly, some countries are actually in decline. This is a trend that needs to be stopped. Countdown looks at equity. And what we have shown over several reports is that coverage is higher for richer households. The poor do not get access. And these inequalities are actually greater for interventions that require a strong health system. For example, skilled birth attendants. We also find that subnational variations exist. And in this chart, Bolivia in green, you can see that the variation in coverage within provinces, states, or districts is less variable compared to Ethiopia in yellow and India in slight orange. Health policies matter. They're precursors to implementation. And what we have managed to see is that these policies are implemented at variable rates or actually introduced at variable rates. And what you see there in the light green bars are policies that have been introduced in 2008, and those in the dark green bars, policies that are introduced in 2012. And what you see, for example, is that policies that promote postnatal visits, initially, there were very few, but in 2012, we had 30 countries that had implemented these policies or put them in place. For community case management, using antibiotics for treatment of pneumonia, the number doubled from about 18 to 38. This is progress, but there's still amount that needs to be done. Human resources, national investments are critical determinants of coverage. And 53 countries are still facing a human resource crisis. National investments in reproductive, maternal, and child health remain very low. You can see that with the chart on the left. Out-of-pocket expenditure is too high. Official development assistance to maternal, newborn, and child health is on the increase. In 2009, a total of $4.5 billion was provided to this sector. 3/4 of that went to child interventions. And what you find is that in real terms, there is an increase, but in actual fact, the percentage increase per year is on the decline. And that is the chart on the right that shows you the percentage increase between 2006 and 2009. This is another trend that needs to be reversed. And so as I stand here before you, you will wonder, So what? The information is here. Is this going to be another report that we take home or take to our workplaces and put on our shelves? I urge you to think about what you can do with the information contained. Let's invest in saving women and children's lives. Let's implement strategies to ensure access to essential interventions. You can see variable coverage. Let's inform, let's communicate, and build partnerships and demand accountability. There is no room for complacency. Let's give an infinite value to every single life. Let's make a difference. Let's act now. Thank you.
Thank you. Thank you, Dr. James. You have given very good, very nice presentation on behalf of Countdown to 2015. Actually, I wanted to call the question and open the stage for question and comments, but there is no time. So may I request you, if you have some question or comments, you can use your email. I would like to conclude now. I would like to end this session with few closing remarks. While we have looked back to see what we have achieved, it is very important that we look to the future and accelerate the progress towards eliminate child death. You are all aware that nutrition plays an important role in the child survival. And newborn age needs special focus on them. In India, we have been able to set up Prime Minister's Nutrition Council and a strategy for adolescent addressing nutrition security. Also, in our 12th five-year plan, we have enhanced the budget for health from 1% GDP to 2.5% GDP, which will ensure health and nutrition convergent programming. Some of very valuable thoughts were shared by US Secretary of State and our Health Minister of India yesterday. Today's panel has also shown interesting dimensions on learnings. What emerged very strongly across different speakers is that problem need a multi-sectoral response and a coordinated efforts across different stakeholders. And I am confident that the wide spectrum to stakeholders in this room will be fully committed to make their best efforts to collectively address the issue. Thank you, and I look forward to getting the final report of the two-day deliberations from the organizers, so that on my part, on my ministry, I am Minister in charge of Ministry of Women and Child Development in India. I can make the required interventions towards the common goal too. Thank you. Thank you very much.